resources exist, so that the state's not paying for things that in effect are available through another entity. However, the language is very clear that if the need for the service is identified in the individual plan and the service isn't available somewhere else, we're going to pay for it. So it doesn't result in loss of service to the consumer. The third thing that it does is it says wherever possible that when they do the individual plan, they will look at all the different service providers that can meet the need and choose the one that's least costly that can meet the need. And so that's another provision. And the last provision, which is the one that's focused on more here, is experimental treatment. And it is one that, while you'll often hear about it in the area of autism, it's actually experimental treatments have come up in many, many areas back, as I understand it, and it far predates me in many ways. But in the 70s and 80s, there were requests coming in from providers to use LSD to treat people with developmental disabilities. And then there are things that you hear about today like chelation therapy, which is a very valid therapy for taking lead out of an individual's body. It's something that has been marketed sometimes to be used for purposes of autism. There have been other types of things that are experimental, and sometimes they're proven therapies for something. They just haven't yet been proven for the purpose for which it's coming forward. And so the questions that you had related to this have to do with what direction and clarity we've provided to the regional centers. Again, with it being an individually driven decision, I don't know if Consumer Terry down in Inland Empire has a lead problem. Maybe Terry needs chelation therapy. So it's not for me at the department to decide if I need it, because I don't know what Terry's not being me, but Consumer Terry's health conditions are. But what we have provided to them is there was a whole national project that looked at research around the world on different types of therapies, and it didn't make decisions about them. It just basically said, here's all the research, and the research tells you this is something efficacious for this purpose, this is something that we're still in question about. And so this does provide them with guidance. We've had conference calls with them, we've sent them letters explaining to them what the National Standards Project has laid out. Have there been problems with, the next question was, have there been problems with implementing this model, and lawsuits in particular? I think a couple things in that regard. One is that there was a lawsuit filed in Southern California related to an autism program, and it went to court, and the court ruled that the regional center needed to continue to provide the service. In addition to that, one of the things that we've been doing throughout all of this is tracking, trying to find all the data on each issue where we can track impact, and so we've been tracking fair hearings. And in the area of everything I just described, there's been 113 fair hearing requests, and 19 have been granted, to give you a sense.
I love your grasp of the issues and your very complete answers, but we're really running late, so
okay, happy to go quicker. Happy to go quicker. Okay. So the next item pertains to the Early Start Program. The Early Start Program, we've got slightly under 30,000 babies in the program. I just wanted to clarify for the... Oh, I passed transportation. I'm sorry.
I was going to say, I was getting confused. I said, what happened to transportation?
I got going too quick. Okay. I flipped the wrong page. Transportation, as part of the reductions, there was a proposal to emphasize the need to use generic resources for transportation. So it basically says, if you're capable of using a lower cost transportation, health and safety-wise, that they're going to encourage them to do so. If you're a child and your parent can provide the service, we're going to encourage them to do so. It does not prohibit payment for transportation if the parent can't do it, if it's going to adversely impact the parent or the child, if they can't make it to a medical appointment. So the transportation is basically going to the original statute of using generic resources wherever possible.
So how flexibly is that written? And the example that came to my attention, of course, coming from a rural area, is there's not adequate public transportation in many rural areas, and if a family lives very long distances from services, then transportation and not covering transportation costs obviously can be a significant problem for them.
The transportation in the statute has to be available and accessible to them and has to meet their needs without placing them at risk. So if there's
to your
no
knowledge,
public,
people are not being denied who...
Nope.
Okay.
Nope. If there's
We will-
no
We will send complaints your way or the regional center's way if we hear otherwise.
Yeah,
because we
and
have-
I know in your area, the regional center has spent a lot of time with us because they don't have public transportation alternatives, and that's one of their higher cost services.
Well, especially if the service is sometimes there's local, if you live in Eureka or Lake County, there's a local transit, but if the service is the next county over,
Yeah, exactly.
then, a Greyhound doesn't run there anymore.
Yeah, if the
So-
service isn't there, then there's not the requirement.
Okay. Well, I'm glad you clarified that, and we'll try to make sure if we hear the examples of it to relay that to the clients and their advocates. Yes, Mr. Bell.
Okay.
Yeah, having served on the Regional Transportation Agency for 22 years, I know that the federal government in the new laws that they're developing on transportation and transit are looking at providing some kind of direction for transportation for elderly and disabled individuals. One concept that's being done right now is, like in metropolitan regions, is a regional transit pass, which we might want to look at in terms of a cost-saving idea to allow your department to purchase in bulk, in other words, bulk buy regional transit passes as an affordable way of providing transportation without, because right now it's sort of, individual. There's all kinds of different ways you pay for transportation. You have to handle a lot of paperwork, et cetera, et cetera. This might be a way of getting, for those that can use public transportation, bulk buy regional transit passes. Also, bulk buy contracts with taxi cab operators and paratransit operators, and have one centralized coordinating scheduling program where they have one line to call. If they need a ride, they just call a particular line, and that line will provide them with access to a scheduling person who would provide the time and place and manner of transportation for that person, whether they need a lift truck or some other kinds of special assistance in terms of the transportation. So those are ideas I think they're talking about. I know you can buy the regional transit passes right now in many communities, any metropolitan areas. So I think those ideas could be explored as a way of saving money in terms of the regional centers and the department as a way of bulk buying these transit passes. Thank you.
Assemblymember Bell, we'll look definitely into those ideas. And some of the contracting stuff, some regional centers do that today, and there was a whole LAO, I think it suggested that we look at that, and there was a research project underway when I arrived at the department. And what they found was that, I think because it's so different center to center, that it wasn't ending up being cheaper when each center did it. But I guess the question would be whether there's a way to do more of a statewide thing like some of the stuff health does.
Yeah, I think if you did it statewide, it'd probably be easier.
It'd be cheaper.
Where the department can figure out in which regions and which counties, which transit agencies do sell these passes, and contract with the operators directly, and develop. We have, the regional transit pass is what you really want, because that will get, like in the Bay Area, that will give you access to any transit operator in the Bay Area. All 29 transit operators will honor a regional pass card, including the train, BART, Muni, et cetera, all the transit operators, the bus systems. So you'll be able to get on any operator with just one card, and that would be the preferable way. Other than that, you have cards for each transit operator, which is not as good.
Right.
Okay, thank you.
LAO, any response on transportation? Okay, we'll move to early start now.
I got going too quick. Okay, so the Early Start Program. I did want to clarify, in the Early Start Program, we've got approximately 30,000 babies that we serve, and as a result of the budget cuts, no babies lost services. What happened is about 3,200 babies are getting a lower level of service in a prevention program, which is case management and referral, but every baby goes through intake, gets a complete assessment of their needs, and then after that, the determination is made that what program they go into. So we are serving about 30,000 babies now, and the LAO mentioned we are slightly less. In terms of the reference, so the reference to infants and toddlers not getting services, they are all being served. There's none that have been turned away if they are eligible at all.
So there is not a change in eligibility standards that eliminated some?
There is a change in eligibility standards, but as part of the stakeholder process, we put in a safety net for those changes and created a new program called a prevention program. So the babies, when they come in the door, if they don't meet the standards to be in the Lanterman program or Early Start, they go into prevention.
Okay, thank you.
Mr. Chairman, I just want to understand if you could get me to show the list of available services for the Early Start Program versus the prevention, so I understand what the difference is in terms of levels of service for the respected people that are in each program.
Absolutely, we'll get that to you.
And we are confident that there's sufficient providers to handle the infants and toddlers who get referred to the prevention program?
Actually, so far there's been 3,200 babies referred to the prevention program, and one of the things that we did in setting it up was require them to work with the family resource centers, which are existing resource centers that each regional center has to contract with them. So yes, we believe so. Now they will be referring out to other types of services, and at that point I couldn't completely answer.
Okay, thank you. Aleo? Then we'll move to cut and respite hours. And just let me ask you up front, is this, if somebody's impacted in terms of the loss of the summer camp, this is where that would fall, is under respite?
I'm sorry, I didn't hear you. I apologize.
Oh, okay, I've been told, I got the answer up here, so.
I'm sorry.
Go ahead and present on cut and respite hours.
Yes, the budget proposal, without going into great detail, does cap the number of respite hours that are available to families. The questions that we were asked was, has the department been analyzing the impact? We are doing what we can to identify the impact. We have surveyed the regional centers, and we're finalizing that data to find out how many families were impacted. There are about 66,000 families that got respite before these changes. We are seeing the utilization of respite actually drop. The number of people that are asking for respites down about 8%, and the cap wouldn't affect that. That wouldn't affect eligibility. It could be the economy overall. We also, in terms of the comments here, we are not seeing any admissions to the developmental centers. Those have to be done through a court order. They wouldn't come in because somebody's respite hours were reduced. We also have not seen an increase in out-of-home placement. We've actually seen a decrease, and we do a December over December check every year. And for out-of-home placements for both kids and out-of-home placements that aren't independent living type for adults, and they are down. In this area, we have 900 fair hearings. There have been 69 decisions with 13 granted. And also, regional centers have issued it. The statute allows for an exemption. Okay. If they have special needs, the statute allows for the regional center to give them an exemption from the caps, and they have issued 2,400 exemptions. And I guess your last question was impact on number of providers. We have seen 23 new provider agencies in 2009 and 12 since actual implementation of the TBL.
Okay, I'd like to ask, does the department policy consider HSS hours as generic resources?
Yes.
And how does this affect a consumer's respite allocation?
Actually, by law, we have to look to IHSS first, and part of the budget stuff last year even looked to that further. But in terms of if they have needs above the IHSS hours, or if they've not yet been approved for IHS hours, the DDS can fund services. They may not be respite. They may be in-home health type support, or not health, in-home support services where the family's actually in the home. So it may not be a respite type service.
Okay.
But it doesn't change the amount they're eligible for. It's just who pays for it in reality.
Okay, thank you. Aleo? Nope. And so that takes us to temporary suspension of services. Oh, I'm sorry. Mr. Bell.
Okay, this is personal, of course. I think that doing a better, maybe as a strategy, we should develop a strategy of organizing parents to support one another, parent support group, as part of the respite program. So it's not just getting time off where you can go away from your family member that is in the system. It's actually having other support systems where you can go and be with other parents. Mm-hmm. And I think some type of program that you can develop to encourage parents to help other parents, such as volunteer organizations and getting nonprofit groups involved in that, would be a strengthening of a system of respite care. And I would encourage you to, and I'd be happy to talk about ideas on that with you, because that's actually how we do it. We actually figure out who we can talk to, you know, which parents can talk to which other parents that have children with similar system. You know, that's what they do. Okay, so I think that helping to organize and strengthen that network, I think, is going to be a very important thing as if we're to survive as parents and working through the budget cuts. And if that's a new program, I'm sorry, but I think that, you know, if we have to survive, that's how we're going to have survival mode for us.
I really appreciate your comments, Assemblymember Bell, and I know, having worked with you with the closure of Agnews and the families there, one of the most important things to them was to keep that continuity and that support and that network going, and it really, I think, has made a big difference for them, and I'm sure for the families in the community as well. So we'll definitely look into this. I took good notes.
Okay, so now we're at temporary suspension of services.
I found transportation. I had it in the wrong place. Sorry about that. Temporary suspension of services. This was the most difficult decision, I think, that we came to with the advice or the input of the stakeholder work group. In terms of looking at services that might be suspended until the budget situation could improve. This does assume that non-medical therapies, social rec, camping, and this is where you mentioned the camping program, that those services would be suspended unless they are determined to meet a particular need of the individual for their physical or mental development. We do have, we believe, about 13,000 to 15,000 consumers who were receiving these services prior to the law could be impacted by this. We do have a number of fair hearings in this area. There have been 1,256 fair hearings with 275 decisions, and 77 have been granted. So this has been an area of concern. This is tied to an individual choice budget, which is also mentioned on your agenda. And we are working with the Budget Advisory Group to put that together. And we've got another meeting coming up at the beginning of April where they're going to meet with a consultant that we hired to develop the budget model. And so the consultant has developed it and ran it against our data system. And so they're going to brief our stakeholder group the first week of April, I believe, and then we're going to bring them all back together again. It's really hard to put it together because of the amount of money you have to save to lift these caps.
Okay. I guess my question would be, with the individual choice model, could not some of the services that have been suspended be if the consumer was choosing,
Yes.
for example, couldn't summer camp be considered respite?
Yes, with the individual choice model, it will allow exactly that. It will actually uncap the services for the people that do it. They can choose how to spend their budget. So we're trying to develop it. It's unfortunately very difficult to put together, because you have to have so many people participate, and I think the advisory group would prefer that it be completely voluntary. And so we've got to figure out how to create something where you'll have enough people volunteer.
Well, so if we're suspending while we're looking into or developing the individual choice model, we're at risk of providers or services going away and no longer being available to the consumer as part of their choice menu.
I think in terms of respite, I don't know. We've not seen that yet. In terms of respite, we've actually seen an increase. But in terms of some of the other suspended services like music therapy, I think it's called HIPPO, it's equestrian therapy. Those types of things that may not be able to draw people in outside of what they receive from us, I do think that they're going to have a difficult time continuing to operate.
And what about summer camp?
Summer camp, possibly. It'll be last time when this went into effect, the budget, while it was signed the end of July, the process that we implement in our system allows for about a 60-day lag because you provide a notice to the family and then they have the ability to file a fair hearing. Well, that took care of summer camp. So that lag, we won't see that till we get to this next year. We did actually see a number of families purchasing summer camp as something that they believed that they wanted to do. About half our population, 130 some odd of our population are Medi-Cal eligible, and the balance are not.
Yeah.
So,
okay. Any LAO comments or questions? So now we're at the 3% cut to regional centers purchase of service and operations.
it's the same thing we discussed earlier. I don't know if you want to go through it again. It was just extended for 10-11.
Okay. I want to say that I appreciate yours and the department's effort to go through the stakeholder process to try to, nothing's ever perfect, and I know not everybody can't be possibly always happy, but you've at least, I think, made more of an effort than in many other parts of state government to try to figure out how to minimize the impact of the reductions and do that in an inclusive way, so appreciate that. Yes, Mr. Bell.
I had one request. I know the Department of Managed Care made that ruling last year on medical necessity for autism, and you know what I'm talking about. It was at the request of the private insurance companies that we're trying to get out of providing care for people in our community with autism. I would like to know if your department was consulted, or is there an estimate of what the cost shift to the public sector was as a result of that ruling? I think the ruling that private insurance no longer required to provide insurance coverage, health coverage for certain conditions has severely negatively impacted many families, and I would like to have that looked into and investigated, because I think it goes counter to the direction that you said when we will attempt to help ameliorate some of our budget cuts by encouraging coverage for people with private insurance. And I think if they're going to close the door on us when we're trying to get coverage for these people, that mainly children that have autism, closing the door for their private insurance coverage, I think that goes counter to that direction. So I would like to have that looked into. I think I have very serious questions about why that was done and whether or not it's a good decision. And it seems like one department's doing one thing and another department's doing something else. And so that, Mr. Chairman, I just want to make a statement about that on behalf of many of my constituents that have complained to me about this ruling on behalf of the autistic kids in our state.
Assemblymember Bell, if I may, we have met many times and continue to meet with Department of Managed Healthcare, and I am familiar with what you're referencing. A couple of things. One, I think for us in talking with everybody and both our colleagues within the administration and I think talking with the managed care plans, I think that there's more of an awareness now of the statute requiring us to be payer of last resort. So I think that has changed significantly. The other thing that I do think that has improved is part of that ruling, and I know the part that you're referencing, there was also something that is helpful to us, and that is a requirement that if they have things that they normally provide, like OT, PT, and speech therapy, it required the plans to cover those services for people with autism. And so we are starting to see a little bit of a change in that regard. There's still a lot of issues that are way beyond my area of expertise when it gets to insurance that we need to noodle through. And I'll share with my colleague, with the director of DMHC, this discussion today, and then maybe we can follow up with you further.
I think they also shifted a lot of the costs to the public education, special education programs that are now burdened with a lot of costs that were formerly medical costs and now from private insurance and are now burdened on the public special education system in California. And that's a concern I have. I think we ought to investigate this because I think it costs the state money. And when we have things that affect the state budget of this magnitude, I think it's something that ought to be disclosed and discussed. I would like to have that investigated.
Okay. Last item on the agenda is that in the 10-11 budget, the department has been directed to return to our budget advisory group to try to work with them to identify $25 million in additional general fund savings. We have met with them. We'll be meeting with them again the middle of April on that, and getting input from them on ideas so that we can put something forward.
Okay. Any response or final closeout from LAO on this? If not, okay. Thank you very much for the presentation. We'll see you next time around.
A few minutes, I think.
What's that?
In a few minutes for your scenarios.
Oh, that's right. Not going away. That's what I meant by next time. That's what I meant by next time around. Okay, our former colleague, Ms. Dauscher, is with us. Welcome. Good to see you. Director of Department of Aging, and we're on page 64. Did you want to make any general comments, or should we plunge right in, given the hour? Okay, the first item is elimination of all general fund for most community-based services programs.
Yes, you asked us to talk about how we have implemented these cuts, and I'd like to tell you that we have no proposed reductions for the budget year 10-11, and so that I will be addressing
It's purely adopted items from
the adopted cuts.
Going into effect in the budget year or in the current year.
Right. And I'd also like to point out that the senior employment program was cut in 08 and 09, so that lags behind a year. It was prior to this past year, but I'll still touch on that because it's on your list. When these cuts came down, we met with the AAAs. We regularly meet with our local area agencies on aging and communicate with them about, their concerns and how to implement. And so we had numerous conference calls about this, and then the department put out some guidance, and we stressed, and they wanted to do everything they could to transition clients who were going to have services eliminated into other programs, and in many cases they decided to backfill the cuts. The cuts were actually made for the first 3 months of the current year. So 3 months of funding was allowed and 9 months was cut. So in many cases they did backfill these programs with Older American Act funding, which is federal dollars, or local sources that they might have done fundraising or they did referrals. I'd like to point out, though, and not minimize the significance of the cuts, that it's a zero-sum game and real money was lost. But they did make the priorities at the local level as to what was most important in their community, and so they might have shifted some funding over to some of these programs to continue them, as they were, in many cases, a very high priority. Your second question, I'd like to let you know that we did a survey in November, and these are the impacts that we know about based on our November survey. And I'll just kind of go through quickly the programs. The Alzheimer's Daycare Resource Centers, most of our AAAs did decide to continue funding these. And I'd like to mention that this is an overlay enhanced service package that goes to clients who are at either adult daycare or adult day health care. And for this program, you, unlike our Older American Act programs, which are for older adults, in this case, you can be at any age, 18 and older, if you have Alzheimer's. So in many cases, the area agencies on aging did decide to continue funding for this. In the cases where it was eliminated and you had a person who was under the older adult age of the Older American Act funding, then their continuation depended on whether they qualified for adult day health care or adult day care services as to whether they would have been eligible. In terms of the Brown Bag program, Brown Bag was a program that provided food, and in many cases, again, the AAAs did decide to continue this. I'd say two-thirds of them are continuing it for this year. I'd like to point out, though, that the food banks also, they usually coordinate with food banks, so that was a kind of a system, a backup safety net. Again, it's a zero-sum game, so, if there's money that's taken out, there is less food, so I don't want to minimize that. Linkages, it was about half and half of the area agencies who decided to continue that. In many cases, they decided not to cut it off after 3 months, but to kind of do a reduced level of funding for the whole year, or to try and shift money or find local money to backfill. This was a very high priority for many of the AAAs. You have in your documents that it was 5,500 clients. It's 5,005, so I think a number got transposed there. In any case, Linkages is open to anybody 18 and older. So in the cases where the AAA decided not to continue funding and the program was cut, the Older American Act funding could not serve as a backup because in many cases the clients were younger than was the federal funding was allowed for. So in those cases, it was, I'm sure, more difficult to find alternative placements or referrals or means to service those particular clients. In terms of respite, most I'd say two-thirds of the AAA did discontinue this respite program. However, I'd like to mention that the AAAs do get family caregiver funding through the Older Americans Act, and this has a respite component, so that could pick up some of the slack. It's a pretty well-funded program in terms of Older American Act funding, but again, nevertheless, money was taken out of the program, so there was, I'm certain, less respite than previous years. In terms of senior companion, most of the programs did decide to eliminate the senior companion program, but again, the Older American Act money does have funding does have supportive services funding, which can backfill all kinds of visiting programs if that is a high priority at the local level. So we don't know exactly what each local entity decided to do, but I can assure you it was determined locally and not at the state level. It was decided what the priorities were. In terms of Title V, which again was a cut the previous year, not the current year, we did see fewer persons served, 420 fewer persons served. However, ERA funding came in at $2 million, and then we just now have been awarded $5 million over the next 18 months for this program. So the federal government is putting money into the senior employment program, which is good news. You asked the second question about our continued oversight of the program. Our oversight will be limited. We are responsible for overseeing this 3 months of funding that was provided. And so that will mean that after the current year ends, we will be doing monitoring and auditing of that funding. I'd like to point out that in terms of the state ops funding for my department, we were given 6 months this year and none for the budget year. So we will be just, doing this because we're required to, but there won't necessarily be any funding associated with it. And after that requirement is done, we will have no requirement then to oversee any of these programs that folks decide to continue using local sources, unless it's Older American Act funding, which we normally oversee through our normal processes. Lastly, you asked us how the beneficiaries are doing. We are in the middle of doing a survey right now, asking our local area agencies on aging for information. But what I need to tell you is that we never had a statewide data system, collection system for this program. These programs were funded entirely by the State General Fund, and we never had a data system. So I can't really tell you much about it. That was on our list of things to do in the next couple years, but now it won't happen. The other piece, though, is that the Olmstead Committee, and I sit as a member of the Olmstead Committee, is very interested in working with researchers and foundations to measure the fiscal impact and the human impact of these budget-related changes, particularly to the home and community-based services in the state. And so the committee has really started working on this and is seeking to develop a baseline of what exists and what has existed before the cuts so that it can be measured in the future after the cuts. And I think we'll be looking at individual people and trying to make it as valid as possible. So this is something that's in the works and that is a need that we all recognize. Be happy to answer any questions.
Okay, well, a general comment, and this is when I could make it any number of places. It's not specifically just with the aging programs. Another example of one that has been, and is coming up, I think, under Department of Public Health, is for there to be general fund programs which received complete zeroed out funding for life and death items is just unconscionable. What I was going to mention was the domestic violence shelters, but certainly some of these senior programs fit in the same category as well. So it's completely understandable in this environment that shared pain has to be spread around, but boy, the across the board absolute devastation here is just, as I said, I'm not. There's nothing personal about you, Ms. Dowsher. I'm just a general comment, and hard to comprehend, quite honestly. Considering we all presumably have seniors in our life or have had seniors in our life, and someday we'll very shortly be seniors ourselves. It should be an understanding of how critical these services are. You mentioned food banks as a fallback. What's being experienced at food banks? Do you have any ability to say whether that, because my general impression is that their support base and their capacity is severely eroded as well under the economy and budget cuts and all the things that are being faced?
Well, I listened to Assemblymember Bell talk about the food stamp program, and I would echo that we are certain there are hungry seniors out there, and that the food banks have been hit very hard, and everything you read is that they're not getting enough and they're turning people away. So our little piece, it wasn't a lot of money. It was $540,000, but that's $540,000 that was leveraged.
Well, if you spend any time serving meals at a homeless program, you know that at the end of the month the numbers grow, and they're not necessarily homeless people. They're simply many times seniors who just have run out of food for the month. They run out of money and they run out of food. So, with regards to the Alzheimer's daycare resource centers, how many sites have received funding from the AAAs, and at what level?
Let's see, the Alzheimer's daycare, they had 25 AAAs planned to continue the program and 8 planned to discontinue them. There were 57 centers before we started, and I don't know how many of those centers, some AAAs had decided to fund more than one center, and so they kind of split the money around, and so I don't have the number as to how many centers there are left. But it's 25 AAAs decided to continue funding. I might add, we don't know what's going to happen in July 1st. They were able to hold on this year, whether, and that's part of the information we're asking, but I don't think they'll probably make certain decisions until they're more certain about the funding for next year. So next year, we don't know.
Okay, thank you. Legislative analyst?
Thank you, Mr. Chair. Jenny Bello from the Legislative Analyst's Office. Just a quick comment that, as Ms. Dauscher indicated, these are new reductions that had partial year funding for all of these programs, and the area agencies have had some flexibility in how they're able to implement them. So it's difficult at this time to evaluate what the impacts are, but as we get further and further away and things change, we'll be able to look at that a little more closely, and as the survey results come in as well.
Okay. Well, we considered this item as adopted cuts, but it's pretty important to recognize that they're proposed to go forward, and
Right.
it's not like it was a temporary cut.
Correct.
So, okay. Any other comments or questions? Thank you very much for so patiently waiting for your turn up at bat. We are going to the Department of Public Health now. The other thing about a number of the governor's devastating vetoes is that there was never really a public hearing. So really, I mean, what we're going to be doing more as we go forward, but in considering the impact of reductions, this is sort of a retroactive public hearing on what the results and the impacts are. So, okay, that being said, would you like to make any initial comments, or you want to just plunge right in?
Of time, skip any introductory remarks and get right into the business at hand. I appreciate the opportunity to come and answer questions.
Well, and we appreciate your presence here. Thank you.
The first area that we'd like to discuss are adopted reductions in our maternal and child health programs. As you are aware, we've all the general fund supporting these programs have been removed, specifically with the Black Infant Health Program, the Adolescent Family Life Program, and the county maternal child health grants. I have with me Dr. Shabir Ahmad from our maternal and child health division to give us further impacts of those various cuts in those programs. Dr. Ahmad.
Thank you, Mr. Chairman. Shabir Ahmad, the Chief of Maternal and Child Health in Department of Public Health. The Black Infant Health Program, there was a reduction of state general fund of $3.9 million that also eliminated an additional $3.2 million in matching federal funds, that is Title 19 drawdown. And these funds were used to support health, education, health promotion, social support, and service coordination to pregnant and parenting African American adult women. This total loss is $7.1 million to the program, and the program is in 17 local health jurisdictions where 95% African American births occur, live births occur. Out of a total 13,200 clients which were served in 2008 and 9, for the current year, we estimate that at least 7,049 clients would not be served under the Black Infant Health Program. For Adolescent Family Life Program, there was a $10.7 million reduction in the general fund, and that also eliminated additional $5.4 million in matching federal funds, again, Title 19 source, and these funds were used for pregnant and parenting teens to promote positive pregnancy outcomes, effective parenting, and socioeconomic independence, where education at high school was the major focus. The total elimination of funds from the Adolescent Family Life Program is $16.1 million, and out of 17,000 clients which we served in 2008 and 9, 12,000, we estimate that 12,027 clients would not be served in the current year with these cuts. For the local MCH program, which is in all 61 local health jurisdictions, the impact of the program is not really known at this moment until we analyze the data by the end of the year through the progress reports which we get through the local MCH program, and also the administrative data we collect at the department level. There was a cut of the general fund was a $2.1 million cut, and with it also elimination of federal match in $2.7 million, and the total loss was $4.8 million to local MCH program. In addition, there was local assistance. In addition to local assistance budget cuts, there was $3.5 million general fund state operations eliminated, and out of that, 1.6 was for California birth defect monitoring program.
Thanks, Dr. Ahmad. We'd be happy to entertain questions or additional concerns on this item.
Okay, I would just make similar comments on, devastating, disproportionate cuts for critical programs. LAO.
Thank you, Mr. Chair. Lisa Morawski with the Analyst's Office. We would just note that we want to credit MCH programs with doing a fairly good job of collecting data on the impacts of these cuts. We have received data from them on county-by-county impacts. It's difficult to quantify what the outcomes are, since these programs do take a public health approach. But in general, these programs try to reduce teen pregnancies, provide young parents with appropriate parenting skills, reduce infant mortality and premature birth. So to the extent that funding is removed for the programs, we would expect that the indicators, if they were effective programs, that the indicators would all start to go the other way.
I might mention that another reason why it's hard at this time to quantify the impact of maternal and child health grants to local jurisdictions is that this is relatively discretionary funds to local jurisdictions. So each county develops its plan and presents that to the department for funding, and it may address other different priorities county to county as to what program is actually funded in that program. So it'll take a bit more time to quantify the impact of that across the board cuts in the maternal and child health programs.
Okay, let's move to the Office of AIDS.
Great, thank you. Once again, this program, virtually all general fund was removed from the Office of AIDS, except to support surveillance activities in ADAP. And I've got with me Dr. Michelle Rowland, who heads the program, who will detail for you the impacts on the various other programs that have been eliminated or reduced.
Well, I'm certainly seeking reassurance that in this case we're not talking about life and death cuts. So.
Good evening. I'm Michelle Rowland from the Office of AIDS. So the general fund represented about 80% of the total resources that we had available in the office to provide HIV testing services and prevention services. And that general fund represented about 50% of our total resources to provide medical care and support services to people living with HIV. The impact estimates that are available in the agenda were developed prior to the implementation plans, and so they were our best estimates of the impact of these reductions, and in many cases don't represent actual individuals, but represent individual services. What we did in terms of implementing the budget reductions was to really reevaluate all of the programs that we were funding to make sure that we were directing the resources that we had available to the highest impact, most efficacious interventions. And as a result of that, we also were able to make the decision to reduce our own administrative overhead costs and shift a fair amount of funding from Office of AIDS support to local assistance. So we would anticipate that the actual impacts will be smaller than the impacts that were estimated at the May revision. That being said, we don't know yet what the impacts will be. I think the most important question was asked by Ms. Evans at the very beginning of the session, which is what's going to happen with the new HIV infection rate. Really, as soon as this happened, we started working with our federal partners, particularly at CDC, to put together a series of evaluations, both modeling studies and also just program impact evaluations, to look at the questions not only related to the prevention and testing reductions, but also the care reductions, on the impact of new HIV infections, on the impact of HIV-related mortality, and the impact of HIV-related morbidity. That effort requires participation from across the range of our office, looking at the epidemiology data and the program evaluation data. It also requires participation from county partners, because many of our county partners also receive these federal funds. So that process has started, but I do not have any data to share with you at this point.
Okay, legislative analyst.
Thank you. We would just add that we are also very interested in looking at this data. We have requested it from the department as well. And we note that HIV treatment is very expensive for the state. So from a fiscal perspective, it's important as well as from a public health perspective.
Okay. Well, needless to say, once again, the disproportionate reduction is something that I think is completely unacceptable. Difficult enough to absorb the cuts on a proportional basis that are going on with state government in general, but not acceptable to take this kind of hit. So we'll move on to a reduction in domestic violence shelters, and all I can say is same comment. Again, I visited after the veto, before we did the temporary fix, most of the domestic violence centers in my district, and it's created chaos in terms of the access to service. And it's not just shelters, it's also transitional services and networking for connection for other types of services. It's helping abused individuals get with legal advice to get restraining orders. It's a whole array of services. It's not just a roof over somebody's head. So, again, life and death, critical and unconscionable to have it completely eliminated.
The next item was the domestic violence shelters. Just over $20 million was removed from our budget to support the domestic violence shelters across the state. I have with me Lori Weaver from our Center for Family Health, who oversees the oversaw the domestic violence program, and she can detail for you a bit more answers to your questions and impact of that reduction. Lori.
Thank you, Doctor, and thank you for having me back for this discussion. As noted in your agenda, the 2009 budget did eliminate $20.4 million for the domestic violence shelters to provide general fund savings. Subsequent to the passage of the Budget Act, SB 13 was passed and signed into law, which has reestablished $16.3 million in funding for the domestic violence shelters. It also redirected funding for the shelters to CalEMA. As a result of the changes in the Budget Act, the staffing that formerly administrated the domestic violence shelter funding was eliminated, and therefore we didn't have the staff to administer the program any longer, and it is now residing in CalEMA, at CalEMA. I will note that in fiscal year 2008-9, approximately 105,000 victims of domestic violence and their children accessed direct services through the 92 shelters that we were supporting in that fiscal year. As for your remaining questions related to the impact of the 20% reduction, unfortunately, we are unable to provide you with that information. That administration now resides with CalEMA. I can tell you anecdotally that we did receive information from some of the shelters in rural areas that because of the funding reductions that they were unable to continue to provide services, and in some instances were required to close some of their shelters.
Do some cross fertilization. Are we aware of whether or not any conversation, I know it's no longer in Department of Public Health, but are we aware of whether there's been any conversations with the administration? Maybe I could ask Finance this as well, in case you don't know, about coming up with an ongoing mechanism, since it was considered enough of a mistake to have vetoed this funding, to find a temporary solution. Has there been any discussion about trying to find a way to find a revenue source or some funding source to keep it alive on an ongoing basis?
Mr. Chairman, John Doyle, Department of Finance. At this point, no, we're not.
No, you don't know, or no, there's no conversation?
No, we're not looking at, we haven't reviewed proposals to continue this program on an ongoing basis.
Well, I'm trying hard not to do this very often in this hearing, but earlier I put a marker on one. I'm going to put a marker on this one that I think and it's a different budget subcommittee now, I guess, because it's at CalEMA, but I think we need to have the two subcommittees talking to each other and try to demand and work with the administration to and the Legislative Analyst's Office to try to come up with a solution that could prevent this tragedy from unfolding. So, does the Legislative Analyst have any comment?
No, not on this. We're happy to provide any technical assistance.
Yeah. One last comment, and then I'll shut up. You know, if I were capable of doing something like this, you know, if I went home, the locks would be changed on the doors. And it's amazing to me that with the chief of staff he has and who he's married to, that somebody doesn't whoop the governor upside the head about this. It is unconscionable. I just have to say that. I'm sorry. And you know, sometimes we men need to be educated and reminded, but I would think somebody would be educating and reminding him, because this is just inexcusable. I appreciate the fact that we came up with a temporary solution. However, most of those domestic violence centers haven't rehired the folks who they laid off because they're very afraid that it was one-time money, so they need to try to somehow skimp and save and live on that money for some period of time into the future. So it hasn't gotten back to where it was as a result of our, at least not in my district. I haven't been all over the state talking to centers, but certainly the ones that I visited in my district are, you know, ratcheted back to bare bones volunteer staffs and trying to survive on the community fundraising and the other funding sources that they can come up with. So anyway, enough of that. We are.
Thank you, Lori. The next item was the California Health Care for the Indigents program. This is the program that reimburses for emergency services at the county level. Over $25 million of Prop 99 monies was removed from the program and redirected. In terms of impact, what we can say is that in previous years we've seen over 400,000 claims partially reimbursed through this program, and that program is totally eliminated at this particular point in time. So, excuse me. Hi, Melissa. I'm sorry. Didn't know if you were here or not. Melissa Andrews is from our Health Information Strategic Planning office and can provide further details about the impact of that reduction.
Well, as Dr. Horton just said, it eliminated the $24.8 million for the CHIP and RHS programs that actually were funding county emergency docs for the care to the indigents. The reduction had the following impacts. The reimbursement is now totally up to the counties for all the indigent care. The counties are compensating providers for this care, and it's shifted entirely to the county or whatever indigent care systems they have. Prior to it being discontinued, CDPH partially reimbursed 477,000 claims annually to physicians for providing emergency services to indigents. And during this current year, we have been closing out the program.
Okay, I guess the question I was going to ask on this one, and I'm sorry I was on the side talking, so if you answered it while I wasn't listening, I apologize. But is there any impact on the federal health care bill on this potentially?
No, we don't get federal funds for this.
Well, not at the moment, but I'm just curious if there's something in the big package that is passed in Washington that would address indigent health care at the local level.
I'm not aware of that. I don't know.
Okay. Well, that's certainly something to be looking at.
Well, of course, you know, I just what we're aware of course, of the health care reform bill is that it would provide a lot more folks who currently don't have health insurance.
Right. Which might reduce indigency. But
exactly. So
but you're not aware of whether there's any specific categories or funding
I'm not aware
attempts
of any
to focused on this particular population. Okay. Maybe some of the expanded clinic money possibly might be available to help serve this population.
That's correct.
So, reduction to Alzheimer's research centers.
Yes, thank you. I just wanted to cluster the rest of these. The Alzheimer's Research Center's Dental Disease Prevention Program, Every Woman Counts, and Asthma Public Health Initiative are all under our Center for Family Health. We've had reductions either in Prop 99 funds or general funds to those various programs, and I have with me Robin Shimizu, who's the Assistant Deputy of the Center for Chronic Disease Prevention and Health Promotion, who can provide further details and answer your questions about the impacts of the reductions in those various programs. So Alzheimer's, right. Robin.
Thank you. The first question that you asked was, what do the health centers do? So I'm going to just respond to the questions as you asked them. This was a reduction from $6.2 million to $3.1 million of general fund local assistance. And we made a priority decision to fund the centers by getting input from our stakeholders when we were implementing the reductions. So we continued to fund the 10 California Alzheimer's disease centers at about $282,000. That was reduced from $528,000 each. They continue to serve or see the same number of Alzheimer patients, which is about 1,000. But what we did was we reduced the technical assistance and training that we provided through to the providers and also healthcare professionals and medical students and also caregivers. The centers provide comprehensive diagnosis, treatment plans, and referrals for hard-to-diagnose patients with Alzheimer's disease and other dementias, and they detect early-stage dementia missed by undertrained primary care providers in local communities who have limited experience providing thorough diagnosis and treatment plans.
Questions about the Alzheimer's?
Elio, have any comment on that?
We're also aware that in some centers they have tried to increase the targeting of services. So instead of providing a comprehensive set to each person, they're trying to target services more.
Okay. Thank you.
The next program was the Dental Disease Prevention Program. Nearly $3 million of general funds was removed from that program, and I'll let Robin detail the impact of that.
Right. Your question was, as a result of the program being eliminated, has there been an increase in demand for dental services through clinic, emergency rooms, or elsewhere? And our answer to that is that we don't really know, but we have talked to the California Healthcare Foundation, and they actually have issued a report that said that dental-related disease emergency room visits have increased by 12%, but that percentage includes not only children but also adults. Your second question was, have low-income schools provided any information on the impact of the elimination of this program? And we, without our local coordinators, we really don't have up-to-date data, but we do have some anecdotal information from former coordinators who have told us that the schools are complaining that there is no preventive services for children at the schools.
Any comments from the legislative analyst on this item? No? Okay. Right along.
The next program is the Every Woman Counts program. There was $4.5 million of Prop 99 money that was redirected and removed from that program. And as I'm sure you're well aware, that added to concerns we had about a budget shortfall that resulted in significant policy changes in that program. As of the 1st of January, we are not taking new enrollees into that program, and we have stopped screening for breast cancer for women under 50 years of age. I'll let Robin detail further impacts of that reduction on our program.
So the question was, how much did this fund shift contribute to the program's overall budget deficiency? And we just wanted to acknowledge that it did contribute to the deficiency. However, we addressed it through the May revised letter, where we identified $7.5 million in prior year breast cancer control account funds for the 910 clinical claims. So we did address it through the May revise.
But despite that, finding those funds, we still had to implement the policy changes, and there was still an anticipated shortfall.
Right,
correct?
thank you.
Well, I believe the Budget Committee has examined this and strongly expressed its dismay. And I know Ms. Evans, if she were still here, would be repeating that dismay because she's been leading, or at least our caucus's concerns on that. Did you want to say anything about it?
Just an anecdote. I was at a Komen Race for the Cure event 2 weeks ago, and a woman got up and spoke who was in her mid-40s and told her story, where she has been in treatment for breast cancer 5 times. 5 separate times where she's gotten treatment, chemo, the whole bit. She's in her mid-40s now. The first time, she was in her early 30s. So 5 times in less than 20 years, she's had a recurrence. And when she said that the first time she was diagnosed, she was, I don't remember what it was, 32 years old or something, the first thing I thought of was this, and the changing of the age limit and the restriction. Clearly she had insurance, she had the ability to access care. But as she was talking, this is what I was thinking about, having been at the hearing a couple of months back. And so when we're going in one direction in terms of health access and all of these wonderful goals, and hopefully now we're going to actually implement it over the next few years. And then we're going in the completely opposite direction on prevention and trying to catch these conditions early on. It's just mind-numbing, the complete contrast that we see. And I think this is something where we need to find some kind of mechanism, even dedicated revenue or something, where we can put some money into this pot. to make sure we fill this again.
I think the message is clearly out there. This is a very high priority, and we're going to be working to find a way to salvage this very, very important screening and prevention program. So, on to Asthma Public Health Initiative.
Appreciate those comments. Just over $400,000 was removed from that program. Once again, Prop 99 money that was redirected, and once again, I'll let Robin give more detail about the impacts of that fund shift.
So the question was, what were all the impacts on the program of this fund shift? And I'll just tick them off for you. We eliminated the funding for the 10 regional health centers. They were funded at about $43,000 each. As of September 2009, we gave each one of them about $10,000 to cover their expenses from July 1st through September to eliminate those contractors. The centers provided training and technical assistance to clinical care professionals and promoted the use of programs' best practices in managing care to asthmatic children, and they saw about 9,000 children while they were funded. But what we had to do was choose to fund instead the Central Valley Initiative, which focused on, it's a population-based asthma program that funds Fresno, Kern, and Stanislaus counties in terms of the asthma burden that's in those counties. And I'll talk more about that during the questions around the trigger.
Okay. Any LAO response to that? So I believe are we not?
Oh, there was another question, I'm sorry. You asked about the basic funding for CAFI. I'll give that to you just quickly. The budget is $1.376 million. The local assistance budget for CAFI is $1.153 local assistance and $223,000 in support.
Okay.
And it is 100% Prop 99 unallocated account funding.
Okay, thank you. And we're now moving to the proposals, starting with the Every Woman Counts program.
I believe we've already addressed that proposal, but
Okay.
I'd like to move on, if we could, to the prostate cancer treatment program.
Okay.
And once again, would clarify that this is not a reduction in otherwise dedicated resources, but a budget shortfall that resulted in programmatic reductions. And I'll let Robin detail further the impact of that.
Right. You asked what is the impact on the health of the men who are being put onto the waiting list, therefore delaying their treatment. And we agree, yes, their treatment is going to be delayed while they're on the waiting list. But as soon as we have a budget in 2010-11, UCLA is going to start enrolling those men again. The prostate cancer treatment program is in place primarily to provide quality of life for the men who are diagnosed with prostate cancer. And so they will be delayed a little bit while we have to wait for a new budget.
Okay.
And then you also asked, have we explored opportunities to increase funding for this program? And I have to say we have not, because we are facing dire other challenges with our budget, and we just have not been able to find or look for other funding for this program.
Our focus here has been working with UCLA, as we do with all of our programs, to try to maximize every dollar we have available to us. That's where we've concentrated most of our efforts at this time.
Okay, thank you. Next, we have proposed elimination of Prop 99 funds from the Asthma Public Health Initiative.
Correct. And this is proposing a total reduction of all other available Prop 99 funds for the Every Woman Counts program. That results in, or that amounts to $22 million. I would just mention that once again, in terms of impact, as I'm sure you're well aware, in dealing with the current year's a budget shortfall and how we've dealt with that from a policy standpoint, we have initiated an aggressive program of consulting with our stakeholders to give us direction on how best to manage further reductions in the program. So at this particular point in time, we're not able to specify or quantify exactly what the impact of that reduction is going to be. Robin, do you have other comments or response to their questions on that?
No, I think you covered it.
Right.
Thanks.
Okay. Well, I thank you very much.
Do we want to?
And then finally, there was an additional reduction proposed as part of the trigger, once again removing all the rest of the Prop 99 money
Right.
from our asthma public health initiative. And once again, we're not able to quantify at this particular point in time what the anticipated impacts of that are going to be.
It would eliminate the program, presumably?
Yes, the California Public Health Initiative for asthma, that will be terminated because it is 100% funded out of the local assistance, which is part of the trigger, the 1.259 reduction there.
Okay. Well, I thank you very much.
Thanks very much.
Mr. Mayberg. And company. So I don't know whether it's a good fortune or bad fortune to be at the end of a long day.
Well, at least I'm here. That's good.
True, and I want to give you credit for that. We appreciate that.
Especially knowing how important these are and knowing past history of both yours and this committee about the interrelationship of all these things. It's probably nice to be at the end of this. So,
well, I'm not sure what you meant by that, but I do appreciate you being here, and I know we share concerns about these critical issues. So why don't we go ahead and jump into reduction to mental health managed care.
I'll try and make this brief. That in this current year there was a reduction of $64 million to mental health managed care, and that was the amount of money that wasn't necessarily dedicated to medical health services from the state general fund for managed care services. And I'll just try and answer these questions. I'll blend the two questions. The question was, how are counties able to fund optional services? Is there any other mechanism? There is other mechanisms, but it's difficult. The primary mechanism would be realignment, but because realignment dollars have diminished so much, that's less of an option. A second mechanism is county general fund, and that's diminished, and that's less of an option. And the third option would be using Mental Health Services Act money, as long as it's not supplantation. And so it does create challenges for the counties, and I think the counties acted in a very responsible way with this cut. Not that they were happy about it, they were very unhappy about it, but they began looking at and doing reviews of what kind of services were being delivered, and looked at a number of strategies that they can implement that would not impact direct services as much as possible. And so some of the things they did were the counties did, not the state didn't order them to do it. This was county driven, and they deserve credit for that. Was they reduced administrative and overhead costs whenever possible. They began consolidating services. They integrated some of the services with Mental Health Services Act. They redesigned and re-engineered some of their programs, things they'd learned from some of the successful programs of Prop 63. They began transitioning consumers to different levels of care, less frequent care oftentimes, or more support groups, more peer groups. They moved people on, that they were able to institute some other cost efficiencies. Some counties went to group therapy rather than individual therapy, a lot more client-run programs, those kind of things, and worked with their contracted providers to look at what are the treatment plans, and are people getting better, and how do we move people on. But at the end of the day, it still did impact services. I don't think that we read every day in the paper that it impacted services, and it varies from county to county depending on choices that they made. And so we really don't have an idea of quantifying how much it impacted services. It varies, as I said, from each county, but whether it's less services, people, a different threshold of entry into services, all of those things were apparent. So the question was, the second question was, what programs were reduced or eliminated as a result of that reduction? We're not really sure that what those particular programs were, because sometimes there were merging of programs or replacements of some of those programs with Mental Health Services Act programs. What we do know is the programs that couldn't be eliminated were those programs that provide emergency psychiatric care, those programs that provide hospitalization, acute psychiatric care, medication. Those programs weren't eliminated. Safety net, but many of those peripheral or supporting programs were either cut back or diminished in ways that happened. We don't have the data right now to see if there's been an increase in inpatient utilization. It hasn't looked like it, but we'll have to wait till all of the billing's done for the year to see if it does have that kind of impact.
Is there a way for you to measure, the spillover effects in emergency rooms and law enforcement activity?
Well, I think it's more difficult to measure the spillover into law enforcement activity, but one of the things that we will be able to measure is billing for emergency room visits. I think where this plays out most clearly, and it's harder for us to get a handle on, are people who are not Medi-Cal eligible, so there's been reductions in indigent services, and those traditionally indigent services aren't traditionally reported. And I also think then just reductions in the amount or the duration of Medi-Cal services. And so our guess is that that there are consequences of not having those support services. Certainly when you read the paper here in Sacramento, they talk about that all the time. It's complicated because, on the other hand, our Prop 63 full-service partnerships are really working well, and so we're reducing. So it's hard to know why we're reducing in one area, because we've been able to institute some really good programs, what the interface is between those programs. But we do know the full-service partnerships reduce emergency room utilization, reduce arrest, reduce inpatient hospitalizations, and so at least for the 25,000 people who are in full-service partnerships, we know that part of the system is working.
And does the intersection between the federal parity law and health care reform give any down the road potential relief here?
I'm optimistic. I mean, that certainly the federal parity law is in the health care reform, and that the more that we can get individuals to be able, 60% of all mental health services are in the public sector, and the more that we can get people to be able to receive mental health care through insurers and through managed care organizations, especially in those instances where they don't meet the threshold of serious mental illness or serious emotional disturbance, we can keep people out of the system. So I am optimistic that if we can work well with the federal government, and as they're crafting the federal parity regulations right now, that I do think that.
And then
that's
if you have
positive.
an expansion of access to care, more people are covered by insurance, and more insurance covers mentally ill people, then hopefully.
Yeah, that's the best scenario.
Good answer.
And it shouldn't then all be government's responsibility to have to deal with this. And I think you addressed those issues. I think Assemblymember Bell talked about the issue of with autism. If you dump coverage from a certain area, it always ends up in the public sector. And so the more we can work to make sure that people have better access to care or have coverage, we do know that with good early care, people do stay out of our system or out of the 24-hour care. So.
Okay. Does that complete your comments on the first item? Any response from legislative analysts?
Mr. Chair and members, just in general, I think the director was saying this, but generally where you would expect to see reductions would be in indigent mental health care, because that's the area where counties have the greatest discretion. So to the extent that they were still using realignment dollars and other dollars to provide for indigent health care, that's now being shifted to cover these contracts with the state, that's where you'll see the reductions.
Well, and of course, the default mental health system we have in our society, which is the public safety system, so which is where folks who are suffering wind up in many cases, if they can't get services otherwise. So, okay, we're moving to reduction to caregiver resource centers.
Very different story, because we do have some statistics on that. The 11 caregiver resource centers budget was reduced by 70% to $2.9 million. And I will just give you really quickly what some of the impact of that is. The assessments went down 88%, intakes went down 73%, and what happened instead of that is consultations and information and referral went up about 80%. So what we were seeing is they were taking less people in, they were doing no new intakes, but they were being able to give people consultation and support. That counseling went down 64%, legal advice went down 88%, group and support activities only went down about 25%, so once again they utilized their resources to maximize the dollars that they had. Respite went down 98%, so it almost totally eliminated respite for folks who were in the caregiver resource program, and and education and training went down a little bit. So direct services were dramatically impacted, the referral services, support services less so, but still impacted, and information and referral went up.
We talked about all the scenarios of multiple impacts on people. We didn't talk about was people with dual diagnosis, and I wish Jim Bell were here because I know it's a great passion of his. But also all the other cuts that are elsewhere in the budget that are impacting these same folks. People who are trying to take care of family members and people who are suffering with these illnesses or trying to live with them.
Absolutely.
Legislative analysts, any questions? If not, we will go to proposed shift of Prop 63 funds to the Department of Mental Health. And I know you're the wrong person to ask this question, but I'm going to ask the question so you can consider it rhetorical. But what is it about the current political moment that makes the governor think that the voters are any more likely to approve this than they did last, what was it, March or April, whenever the ballot measure was?
May.
That's May. So you can try to answer it if you want, but...
I can't answer it except that I think that with difficult choices, that was one more thing to look at and revisit. We did notice that there has been a little shift in the willingness for the public to take cuts, and for mental health, 24% of the people thought mental health should be cut a year ago, 31% does. That's still only less than a third of the people who think mental health should be cut.
This is not the place to get a detailed answer to this question, presumably during a future budget subcommittee hearing on the mental health budget. But just in a general terms, what's the status of the Prop 63 funding in the current environment? I mean, has the revenue from the tax that funds Prop 63 descended at the same rate as other revenues? And I know when I left Commission, there was still, a cushion and money to help get Prop 63 programs through difficult times, but we've been through some pretty difficult times. So I'm just curious. Again, a general quick answer. I'm not.
Quick answer is the best thing that ever happened to us in Prop 63 was going into a cash rather than accrual. So all of the money that we have has been collected in past years. So we're really not spending any money that we're anticipating coming in. We really do have the money to move forward. And so there actually is money to have increases in Prop 63 funding for 9-10 as we go forward. We have plans out, and we do expect that. That money is spoken for. There's less than $100 million of all those billions that isn't spoken for. The revenue, I won't get too technical, but there's a settle up that happens at the end of 2 years from tax returns, and we were able to we got much more money in the settle up just a couple weeks ago than we expected. So the money seems to be coming in. So it looks good for 9/10, 10/11. I think where the real concerns are, because we're in cash, is what happens in the out years when we go forward with this, and that's sort of the answer to the question is with a trigger with cuts, where is money, or how could you deal with money? Would it impact programs? The answer is there's enough cash, and you could make decisions about how to expend that cash that probably wouldn't impact services in the current year or the budget year, but it would have a dramatic impact in the out years as you go forward, especially if the economy, as we're seeing, is slower to recover than we would hope. I mean, there has been an uptick in the last few months in terms of revenues collected, and because we get a percentage of that, that means that the Prop 63 continues to be funded at a little better than we had expected it to be.
I don't know why, but I just have a hunch that the person from finance might want to say something. No? I was just guessing. I thought you might have something to add. Okay. Well, I'm not the real chair of this committee. I'm just acting like a chair today. But as a member of the committee, when this department's budget comes around, I certainly hope that the chair will agree with me that even though we have less of a direct oversight responsibility with Prop 63 because it's got its own oversight process, it will be very valuable in terms of, because you mentioned this earlier, there's this dichotomy of services between the traditional mental health system and the newly emerging Prop 63 services, and so I think they are tied together, and it would be very valuable for the committee to spend some more time focused on this when we have more time than we do right now. So, other questions, legislative analyst response? Okay. Well, I thank you very much.
Thank you.
And I think the word got out because people started clearing out, but blessedly, we've decided to delay our Part 2 till another day. But, of course, I think that was a very important part of today's agenda, so I hope we can find the time to deal with it. There is most of the people who are going to be on there are folks who are here in Sacramento on a regular basis, all but one. And so I am going to ask the one speaker who was invited to be here to come forward and talk to us before we break up for the evening here. And that is Diane Collegian, who's the Director of Area Agency on Aging, Adult and Aging Services Director for Sonoma County Human Services Department. She with us? Oh, hiding over there. I knew you were here somewhere. So thank you for sticking it out. And I'm sorry, I'm really interested in this scenario that we've put together for sort of examining the cumulative impact. But to the extent you can do your part of it in isolation of the rest of it, we'd love to hear from you.
Thank you very much, and I really appreciate the opportunity to address you today. I am Diane Calja, and I'm the Adult and Aging Services Director in Sonoma County and the Area Agency on Aging Director. And I'm here representing the California Association of Area Agencies on Aging. I do appreciate the opportunity to tell you about the impact of the elimination of the community-based services programs for California seniors. These were unique programs. They served a population of people who did not, for the most part, qualify for other services. So these clients are people who, when the programs were eliminated, just do without help. And we don't, as Director Dauscher said, we don't really have a way to track them or to what happened to them without services. We did recently survey our members, the Area Agencies on Aging, about the impact of the community-based services program elimination, and I'll tell you about the survey results and a couple of client examples. The elimination of that $13 million in state funding for community-based services programs essentially did destroy the infrastructure of the aging network and damage the local service delivery system that served older adults in California. Over the years, the aging network has leveraged these limited state funds to generate millions of dollars of local resources to help frail older persons to remain in the community and live with some independence and dignity. When taking into account local match, program income and volunteer time, the $13 million in state funds generated approximately $41 million in services. The elimination of the state funding put thousands of older people at risk, many of whom have already or will end up in local emergency rooms or inappropriately placed in out-of-home care. Many of the programs have continued, but with some creative funding during this year, but we do anticipate that most of the programs will not be able to continue into the new fiscal year. The Alzheimer's Daycare Resource Center served families like a daughter who was caring for her mother who had Alzheimer's disease. Along with caring for her mother, she has young children and a job, and her husband has to travel a long distance to work, leaving her with overwhelming responsibilities. The ADCRC helped her to care for her mother and for her family needs. Currently, there are 11 of the 57 ADCRCs now operating at a reduced capacity, either by decreasing the number of clients or reducing the number of days that they're open. For those programs that are still operating, the clientele may have changed. For example, lower income clients with severe cognitive impairments may be denied services, and middle income people may not be able to afford to pay the full cost of services. It is anticipated that only 2 of the ADCRCs will continue into July of 2010. The Linkages Case Management Program served people like an elderly couple who were both receiving Linkages Case Management assistance from a social worker. They each entered a nursing home within a few months of the program closure because of the lack of support when they no longer had the assistance of their case manager. As Director Dauscher spoke, the uniqueness of the Linkages program is that it served people who were over the age of 18 who are at risk of institutionalization. And Linkages clients were not means tested, so many were on Medi-Cal, but many were not. And so, as it turns out, 49% of the Linkages clients were low income. 17% were over the age of 85. Right now, 8 of the Linkages sites are operating. We anticipate 4 will operate in the new year, though the population that is being served by this program is different and the service model is different than was used before. The other important point about linkages is that federal dollars were claimed through the Linkages program through targeted case management. Some of these clients were transferred to comparable case management programs, but most were not. They were terminated from services because they weren't eligible for anything else. And the hardest hit clients were those who were under the age of 60 with multiple chronic conditions and no other services. The respite program served people like an elderly man's caregiving daughter who was given 2 days of respite to travel out of state so she could be with her sister who had cancer. 4 of the area agencies on aging are operating the respite program right now. It is anticipated that none will operate it next year. The brown bag program served people like a 73-year-old woman who had no alternative but to move out of her home when her public benefits were decreased. She said if it weren't for the brown bag program, she would not have had a regular supply of food. The brown bag programs serve nearly 675,000 bags of food every year. And only 7 of the brown bag programs are currently operating, and we anticipate none for next year. The hardest hit are those seniors living in rural areas and people who lack transportation. The Senior Companion Program served people like a widowed 90-year-old man whose senior companion helped him to clean his home and do his grocery shopping. Cuts in the Senior Companion Program resulted in the loss of 205 volunteers who worked in that program and 130 volunteer hours. Over 2,000 frail older adults no longer have assistance with transportation or housekeeping or shopping. 5 of the programs continued this year. It's anticipated 1 will continue into next year. In conclusion, the community-based services program's cost to the state was minimal, but their impact to seniors and their families was profound. The community-based services program helped people who may not qualify for other public services, and the impact of eliminating these programs is that there is no state-funded support for the area agencies on aging to help vulnerable seniors remain independent and safe. Thank you for your time.
Well, thank you for being here with that very grim assessment, but one that we have to hear, and the whole world of the Capitol here has to hear. So
thank you.
I do appreciate it, and all I can promise you is that we'll do the very best we can under these tough circumstances. So, and thanks for sticking it out here. And also the 2 department heads that are still in the room. I noticed you're here, and I appreciate you sticking it out. Okay, that's all for today, and we'll be making an announcement, I presume, when we have the remaining second half of the hearing.